Welcome. I'd like to introduce Kostas and Carl from the Brompton Hospital in London. Carl is a nurse specialist and Kostas a medical consultant. What I'd like to ask both of you to sort of discuss is why some people with pulmonary hypertension seem to be managed quite well and for many years on oral treatments, tablets, and some require what we sometimes heard and described as more advanced therapies, intravenous drug. So Kostas, why is it, from your experience, that some people require these more complex therapies?
Well, intravenous treprostinil has been available for more than 20 years and it's a very good drug, but nowadays we have oral therapies that we use in patients when we diagnose them early in their management. However, some patients do present with very advanced disease and hence we need to consider stronger therapies, intravenous therapies, at the beginning of their management. In other patients who have been on oral therapies for a long time, have been taking tablets and have benefited from them, unfortunately the disease may progress and hence again we need to consider something stronger, something more advanced, as you said, which is intravenous treprostinil.
Carl, can I just ask you to explain the difference between, when we say oral therapies, what do we actually mean as healthcare professionals when we say oral therapies?
So oral therapies either mean a tablet or a liquid form of the medication, while intravenous therapies are more invasive in that you have to administer the therapy via a line similar to a cannula that you would have in your hand, but it's there as a permanent fixture where the drug is infusing continuously 24 hours, 7 days a week, 365 days a year.
Right, so it's a continuous.
Continuous.
The other thing that you said, Kostas, was about, you made a differential between severe disease. What do you mean by severe disease? Well, because pulmonary hypertension is a serious condition, so serious and severe, how do you make that?
Yes, pulmonary hypertension is a severe disease, but within pulmonary hypertension we have patients who are stable, who present early in their natural history and hence do well with tablets or liquid form medication. Unfortunately, as you said, this disease progresses over the years, tends to progress in some patients earlier, some patients later. Hence, we need to be assessing patients routinely and every 3 to 6 months, not only with investigations, but also discussing with the patient how they're feeling, what their exercise capacity is, what they can do, what their quality of life is, and then integrating all this information to decide at which stage of their disease they are sitting.
And Carl, it's an interesting point that Kostas was talking about. You use that phrase exercise capacity, which is sometimes the 6-minute walk or an incremental shuttle walking test. How do people with pulmonary hypertension in their day-to-day lives, how is it useful for when you see them in a clinic setting, say every 3 to 6 months, to be able to come with a description of?
I think those investigations are important to mention and talk about in the clinic setting as to maybe saying how we've identified changes. But I think more importantly for us is to understand what the patient feels. If they've done, I don't know, 50 or 60 meters more on their walk test, but they say they're doing less at home with the family, where they're not able to take the dog for a walk or they're not able to walk down the street with their partner or friends, those are the significant changes we should be listening to as well, not just clinical findings in the clinic setting. I think because those are the things that matter to the patient.
Would you, Kostas, when you sort of seen a patient in clinic, if you saw a patient who said, I'm not as good as I was, does that mean, right, we need to change treatment? Or would that naturally mean we need to re-investigate? Would there be some common retesting that would be done?
Yes, there would be. Certainly when a patient comes to clinic and they complain of some decline in what they are able to do in their exercise capacity, as we said, then that would trigger a series of investigations, which could be non-invasive investigations, certainly having an objective assessment of their exercise capacity through an exercise test. 6-minute walk test is what we use very often, but also a cardiopulmonary exercise test, but also more invasive investigations, especially when we're worried that the disease is progressing, cardiac catheterization is important in assessing the severity of the disease and then deciding escalation of treatment.
You mentioned that test, cardiopulmonary testing, which
Yes.
not a lot of people get. What is cardiopulmonary testing?
Cardiopulmonary exercise testing is like a standard exercise test. Most people think of exercise test, the test where you go on the bicycle or you go on the treadmill, and then you walk for a few minutes, and then we see how long you walk. With cardiopulmonary exercise testing, there is the addition of a mask where the patient breathes through the mask during the exercise test, and we can see how much oxygen their body is absorbing, and through that have a very reliable assessment of their exercise capacity, but also of the mechanism that make you breathless, and hence it gives us very good information in the clinical setting.
And Carl, what's the primary, if you had to say the first list 2 or 3 primary benefits of intravenous drug, whichever drug it is, what are they to the patient in that initial discussion?
I think that we have to show to them that their quality of life will be improved ultimately, because I think they will have, for many patients, especially if they've been on oral therapies or the tablet therapies, they'll have some pre-existing understanding or belief about the intravenous therapy. So sometimes the intravenous therapy has to be sold as the next step on to benefit the patient, the person, so that they will feel better, be able to do more. By doing more, I mean what that means to them, not necessarily what it means to us in the clinical setting. But also take on board their fears and concerns, because there are the downsides to the therapy, which also have to be acknowledged in the clinical setting.
So is intravenous therapy not suitable for everybody, Kostas, would you say? Or are there clearly times when it isn't suitable?
It isn't suitable for everybody. The timing is important. You cannot offer intravenous therapies in patients who are doing well on oral therapies, who may do well on oral therapies, who are early in their disease, in the natural history. Intravenous therapies are now used as a third-line treatment once you've used the oral therapies, and patients have not responded appropriately or have failed to respond adequately to therapies. I must say that it is important to remember it's not just about quality of life, which is very important, but there is very good evidence that intravenous therapies prolong the life of patients. Actually, if you look at all the guidelines and all the guidance that we have as doctors and nurses, ibuprofen is one of the few drugs that has very good evidence that we can prolong the life of the patients. But of course, to do that, we need to give it in an adequate dose. We need to increase the dose to a certain level where we can get a very good effect.
But manage the symptoms as well.
Exactly.
When you say manage the symptoms, is that symptoms of pulmonary hypertension or symptoms of giving the drug?
Manage the side effects of the drug therapy.
Okay. What are the common ones there, Carl?
Nausea is the biggest and one of the main things, as well as
So nausea is feeling sick?
Nausea is feeling sick, yeah. And diarrhea.
Right.
Those are the two main.
And they can be managed, can they?
They can, and they can be managed, and subsequently the symptoms will relapse and go away, may come back periodically, but the patient is given the means to self-manage those symptoms, and that's the key thing as well, that they are led to be able to self-manage these symptoms.
So when you're starting patients on these intravenous drugs, that you'd have those discussions and you'd have a plan, or sometimes people will go away on treatments and I'm the only one having these side effects. So these would be discussions that you would have.
Absolutely. First of all, patients need to be aware that the physicians know exactly what the side effects are. We know exactly that the side effects are not uncommon when you start the treatment, yet we know that these treatments are very effective. They can benefit the patient significantly by prolonging their life and improving their quality of life. And hence we have these discussions with patients where you say, well, this is a difficult medication. I'm not going to lie to you. It's difficult because you will give you side effects, but I need to increase the dose to a level where I can get a good response. At that point, most patients get, let's say, used to the drug, and hence the side effects usually subside, and then we can increase the medication further. We do realize as physicians it is a difficult medication to give for the patients because of how it's administered, but the benefits are important when you start it at the right time, not too late and not too early.
So the benefits are improvement in individuals, how they feel. I feel better because I'm on this drug. Once you get over that initiation of the treatment, better survival chance.
Absolutely.
Yeah. One of the common discussions I think you hear from patients, this worry of getting an infection on the line or with the pump. What do we mean?
Well, the body's a closed system, and by having this line put in, you expose the inside of the body to potential of bugs, if you like. Mm-hmm. And they can be problemsome, and there are two sources of infection for the patient, one via the line, mm-hmm. or two via the entry site of where the line goes in.
So this is where the Hickman line, or is it sometimes
the
a Grosham line? So this is natural. You've got a potential for entry of these bugs and things like that. Is it really serious, that, Kostas?
It can be very serious. First of all, we need to explain that when you put a line, a permanent line like Grosham or Hickman line, what you do is you have to put the line in one of the central veins, but the line comes out, is tunneled under the skin further down towards your nipple, so it stays away from the vein. So even if there is an infection around where the catheter is coming out from the skin, it is very difficult for it to propagate, to go up the skin and into the vein, and hence cause sepsis, so a blood-borne infection. But certainly, the longer you have the line in, the more chances there are that this rare but very serious infection may happen. So it is very important to maintain good sterility when you make line changes.
And this, Carl, is something that I know particularly the nurse specialists in the PH teams are very involved, isn't it? All that training and support.
It's imperative from the very beginning that people understand the techniques that are involved in trying to prevent this from happening, because there is a consequence of them happening, which is sometimes serious, which could mean that they would have to have a line replaced.
So the line would be taken out.
We
and
can't.
a new
For
one
us, I don't think that it's much.
In?
That's not an issue in terms, because it's a rather simple procedure in order to do. But I think for the person that needs to have the line replaced, it is a significant aspect, a significant time in their life on this therapy. Right. So I think that's really important.
Mm-hmm. But part of the training is for patients to recognize when this is starting to happen, because if there is an infection, we can probably treat it with antibiotics before we consider taking the line out.
And as Kostas said, if you've got an individual at home with a line in and they were worried about either, this exit site, what would you be asking them to do? See the GP or go to A&E? What?
No, I think if it is feasible, we'd be asking them to come to us so that we could assess.
So what? Probably give you a telephone call and say, what do you think? And
indeed, yeah.
But certainly not to ignore it.
Not to ignore it, most definitely not. The longer they leave it, the more risk it is for the
What might an individual with a line see or feel if there was a grumbling infection, Kostas?
First of all, what you can see is some pus coming out at the skin where the line comes out. You can see some pus, red, like a small rash around where the catheter is. But certainly if they start feeling warm or cold, feeling fever, which makes them feel sweaty or very unwell, especially night sweats, and fevers which often may not be associated with a sore throat, so it's not a typical cold. If there is any doubt about the symptoms, if there is any doubt of an infection through the line, a blood-borne infection, patients should be calling immediately the clinical nurse specialist consultant to discuss the symptoms and see whether they need to come in and have some tests, such as blood tests, some swabs in the where the pus is coming out.
This can be quite a challenge, can't it, Carl? Because it can be quite inconvenient and difficult if patients being a long way from. But this is absolutely crucial, isn't it? This is about investing short term for the long term.
I think so, and the significance of them not coming to us could mean a delay in treatment.
Just move it on a little bit, because clearly intravenous drug has a part to play in many people with pulmonary hypertension, possibly, okay? What about people who make the decision to go down the route of intravenous drug, they start it, and then for whatever reason, they really just can't tolerate it, or they fail to respond to that? What next? What conversations then have?
Well, there's 2 points there. There's not responding to therapy, which Depending on what the reason behind the pulmonary hypertension is, some patients don't. And I think we have to take an approach there of saying that we still feel that the drug will be doing you benefit. But a patient today does have the choice to say, I do not want to continue on. We have to manage that person making that decision. And we may have reached what I would call a ceiling of treatment because we do not have any more treatments to give to that person. But what we move on to then is managing their symptoms.
Okay. What about transplantation? Does that come in when a patient fails to respond to it at a certain point, or would you see people who go on to intravenous drug, if they meet all the criteria, to think we need to have a conversation about possibly transplantation?
I think when the patient is diagnosed with pulmonary hypertension, I think there has to be a discussion and conversation on what the treatment options are. But certainly when we are considering putting a patient on intravenous epoprostenol, that is the moment when we need to have a serious and detailed conversation on what the transplant options are. This is a progressive condition. All the therapies we have can improve the symptoms, can modify natural history, but none are, unfortunately, at this point, curative. Transplantation is an option for most of our patients. At the point, we consider intravenous therapies.
And just going back to something you said, Carl, when you said ceiling of treatment, that's treatment that specifically tries to tackle the pulmonary hypertension.
Yeah.
There's always ways to help people and manage people.
Well, there are many more
symptom-wise.
ways to address symptom management and control. There will be more treatments available, I'm sure, in the future for pulmonary hypertension. But at the moment, they are limited to what we have. And once we've reached a ceiling then of giving all of the tablets and the medications that we can give, minus the intravenous therapy for a patient, then we have to think about the management of their symptoms, of breathlessness, of reconditioning them to think, I can walk from here to there and resting appropriately. So then there's also then the need to introduce other healthcare professionals, if they've not already been introduced, into managing that.
Nobody's ever left on the road and said, well, that's it, there is never no more.
No. By deciding not to continue with an intravenous therapy, that doesn't mean that we abandon them.
I'll leave you with a really difficult one, Kostas. Patient, you have a discussion, yourself and maybe the nurse specialist team, you very much believe the best treatment option for Sally, who's got pulmonary hypertension, is intravenous drug, but she for some reason decides not to. It is okay at times for people to make decisions, you're not?
Absolutely, absolutely. I mean, the patient is the person who decides where we go, what therapies they will accept and they will not accept. This is, as I said, a very difficult therapy. Intravenous therapies are very difficult to manage, and not everybody is willing to accept all the side effects and the effect on the quality of life that carrying a pump with you may have. And it is absolutely acceptable. It doesn't mean that we will stop treating the patients. We will try to find alternative options for them. The most important thing for me is to make sure that they understand why I have suggested intravenous therapies, and make sure they understand that even though there are side effects, there are thousands of patients out there who tolerate intravenous therapies very well and have benefited from them. So this is the important thing, to understand that these therapies work. There are difficult therapies, but they're not impossible therapies. So the fear of I won't make it is something that we need to deal together with the clinical nurse specialist, with the patient. And if the patient still doesn't want the intravenous therapies, that's fine. We need to find alternatives.
And Carl, your thoughts are very similar?
No, I totally agree with everything that Kostas has said, actually, with intravenous therapy and the decision-making process. The way that we manage patients has to be a team approach, that we say the same as each other, and that's what I would agree with what he's said so far on the management of trying to put somebody on intravenous therapy, whether they are reluctant.
Right. I think I'm right as well saying, Kostas, intravenous drug was the first real effective treatment in pulmonary hypertension, wasn't it?
It's the real effective treatment. It's been here for more than 20 years, so it must be a good drug. It's working very well. It's very strong. It's probably the strongest medication we have, and I tell our patients that You've had oral therapies, now we have even stronger medication we can provide you. And the fact that we will refer you to transplantation at the same time doesn't mean it's the end of the line. It is likely that if you respond well to intravenous therapies, you may live many, many years still and not require transplantation. So it is not...
I was just going to finish on that one, but you said something quite interesting there, that we refer all our patients for transplantation. A transplant isn't available for everybody, is it, Carl?
No. But exactly that point is important to emphasise. However, the management of symptoms and the ability to do day-to-day activities might be so restricted by the pulmonary hypertension. Often therapy can benefit those patients where transplant isn't an option for them. But it is there.
I'm still going to come back. I'm going to press you both on this about transplant. Yes. And is when is transplant not available to an individual? Is there an age limit? Are there
Unfortunately, there is an age limit. Number one, certainly there is an age limit. Number two, if there are systemic conditions such as connective tissue disease, that can be.
So systemic conditions. What's
systemic
that word?
Scleroderma, connective tissue disease, so autoimmune conditions in which there are autoantibodies that are affecting not just the lungs causing the pulmonary hypertension, but also other organs, the esophagus, and so on, the heart and so on. Then,
so what that means, so there's not only pulmonary hypertension, but that individual might have another very significant condition that prevents them from...
Absolutely, there could be another significant condition, or actually if the pulmonary hypertension itself has significantly affected the kidneys, the liver or other organs, then it may be too late to get to transplant. As you know, unfortunately, there is a scarcity of donors still in the UK. Even in patients who would be good candidates for transplantation, it may be very difficult to get donors to provide the organs.
And again, Carl, it's true to say as well that not everybody that's eligible for transplant would actually opt for transplant.
No, sometimes people refuse to have the transplant or go down that route because they can't imagine having somebody else's organs.
And that's okay, isn't it?
That's okay.
That's
and that's the role of intravenous therapy. As I said, it's there not just for the transplantable patient. It's there for those patients who need to be managed in terms of their pulmonary hypertension so that they can do more and hopefully improve that quality of life.
Okay. Well, thank you, Kostas, and to Carl. Thank you very much.